Hello, and welcome to a discussion on shock and vasopressors. Today we will review the medical management of the critically ill patient. The primary goals today will be to provide an overview and diagnostic approach to various shock states. We will also discuss the use and mechanisms of vasopressors and inotropes. Let's do an overview on approach to shock. So what exactly is shock? In simplistic terms, shock is defined as an evidence of organ hypoperfusion. Most of the time, this will look like hypotension with a systolic blood pressure of less than 90 millimeters of mercury or a mean arterial pressure of less than 70 millimeters of mercury. But many other things can also potentially look like organ hypoperfusion. For instance, decreased level of consciousness, tachypnea and difficulty breathing with desaturation. Cardiac end organ hypoperfusion can manifest as myocardial infarction, cardiac arrhythmias, and potentially pulmonary edema. In later stages, hepatitis, coagulopathy, and potentially renal injury with decreased urine output can also be signs of organ hypoperfusion. Let's quickly review what the determinants of mean arterial pressure are. Blood pressure, or mean arterial pressure, is determined by your cardiac output and your systemic vascular resistance. Your cardiac output is further determined both by your heart rate and your stroke volume, which are affected by your preload, your contractility, and your afterload. There are several categories of shock. The most common will be distributive, in general always presenting as warm or well perfused. The most common examples of distributive shock will be things like sepsis, general inflammatory conditions, anaphylaxis, mixed edema coma, adrenal insufficiency, and potentially neurogenic shock. Cardiogenic shock oftentimes can be contrasted because the patients appear to be cold, mottled, peripherally shut down with a high JVP. Obviously, the most common examples would be things like left ventricular failure, such as seen in an MI, myocarditis, or septic cardiomyopathy, right ventricular failure, and potentially arrhythmias. Hypovolemic shock oftentimes can be due to things like severe GI-related illness, overdiuresis, or hemorrhagic shock. These patients will generally present as cold, peripherally shut down, with a low urine output and a flat JVP. Obstructive shock, in general, pertains to things like tamponade, tension pneumothorax, and abdominal compartment syndrome. The most important thing in terms of management of shock is the rapid recognition of the shock and the type of shock that you're dealing with. For example, tension pneumothorax has to be recognized quickly with rapid needle decompression of the affected side, or anaphylaxis should be responded very quickly with an immediate intramuscular injection of epinephrine. Many times, the approach to shock management really relies on multimodal therapies, for instance, supporting end organ perfusion, either with the use of things like vasopressors, inotropes, or fluids, while instituting particular therapies for the underlying cause. This requires simultaneous initiation of interventions to support blood pressure while thinking about the differential diagnosis. So let's walk ourselves through a case. You are on call in the hospital and you get a 12 a.m. ward call. The patient is a 77-year-old male admitted for a history of small bowel obstruction and found to have pyelonephritis. He is started on ciprofloxacin and has 2 peripheral IVs. Despite appropriate antibiotics, his fever is persistent. He was last seen by the team at 7 p.m. with a blood pressure of 95/60 and a heart rate of 110, but in normal sinus rhythm. You were called to the ward immediately by the nurse. At that time, you're called because the systolic is now quite low. His systolic is less than 69, heart rate of 135, saturating 92% on 40% face mask. Your 12 a.m. reality is 1. You don't know much about the patient. 2. You need to have a good differential. And 3. You need to immediately rule out life-threatening and rapidly reversible causes. So as you take your elevator down to the ward, these are your reality and thoughts. Is this septic shock? This persistent fever could be an evidence of nosocomial infection. Is this potentially anaphylactic shock, in which case you need to have epinephrine ready and consider any new medications that he would have taken today? Does he have a history of adrenal insufficiency? Did someone potentially forget to order steroids that he might have been on at home? Or is this something completely different, like a cardiogenic shock because he had a recent MI? Or does he have right-sided heart failure? Has he even been on DVT prophylaxis? Is this hypovolemia? Does he have C. diff as a result of antibiotic use, or has he been getting over diuresis? Is he potentially bleeding? And finally, is this obstructive shock? Does he have signs or symptoms on physical exam of a pneumothorax or potentially tamponade? These might be quite unlikely, but should warrant a second or two to think about. When you arrive to the patient's bedside, it's really important to do a rapid assessment. This includes rechecking your vitals and checking the patient's airway, breathing, and circulation. In particular, does he have IV access? Is the blood pressure adequate? And is there fluid on the way? You will do this in conjunction with a very succinct head-to-toe exam. From a neurological perspective, check his GCS. Head and neck exam, look for angioedema, hives, or tracheal deviation. This will help you rule in or rule out potentially tension pneumothorax and anaphylaxis. If the patient doesn't have a Foley already, get the nurses to bring a Foley and insert a Foley catheter and check his temperature again. Finally, if you're feeling overwhelmed, always call for help. So what do you think is going on, and what would you do next? You decide to order several investigations, including a routine blood work, ABG, lactate, chest x-ray, electrocardiogram, and concurrently start some management. Your thoughts run through the three following things. Fluids. Should I potentially give vasopressors? Should I change the antibiotics? What I'd like to do now is spend a bit of time reviewing vasopressors. So let's take a look at what the difference is between vasopressors and inotropes. In most simplistic terms, vasopressors tend to act on your systemic vascular resistance, which is very important to maintain a mean arterial pressure. Inotropes, on the other hand, primarily work on cardiac contractility, which helps to improve your stroke volume. Before we talk about vasopressors and inotropes, what I'd like to do is review a few things on basic receptors within your body. When it comes to vasopressor function and inotrope function, alpha and beta receptors are very important. There are two main types of alpha receptors. The ones that we think about the most are alpha-1 receptors, as they are existent primarily in your vascular smooth muscle cells and are important for mediating vasoconstriction. Alpha-2 receptors tend to be found within your central nervous system and help to mediate sedation, analgesia, and platelet aggregation. Beta receptors have several functions within your body. Beta 1 is primarily located in the heart and mediates increased contractility and heart rate. This both increases or improves inotropy as well as chronotropy. Beta 2 receptors are found in your smooth muscles of the bronchi, causing bronchodilation when stimulated, but can also be found in your blood vessels and lead to vasodilation of certain important places, such as dilation of coronary vessels, as well as dilation of vessels to the skeletal muscle. Before we look at each of the vasopressors in isolation, I think it would be important to look at them all together in a group within a chart, just to compare and contrast. The most common vasopressor you will see in the ICU will be norepinephrine. The standard doses are 0.01 to 0.5 micrograms per kilo per minute. It has largely alpha and some beta receptor stimulation. The primary effect will be to increase your systemic vascular resistance, and at higher doses will increase your heart rate. Epinephrine, given at doses between 0.01 and 0.4 micrograms per kilo per minute, has a substantial amount of alpha and beta effect. Therefore, it can increase your systemic vascular resistance, increase your heart rate at higher doses, but also has the downside of potentially increasing your lactate production. Dopamine, which comes in pre-filled bags, can be given at doses of 5 to 20 micrograms per kilo per minute, with varying effects depending on dose. At lower doses of 5 to 10, it has predominantly a beta effect, whereas at higher doses greater than 10 mics per kilo per minute, you are looking mostly at alpha effect. The major effect is basically lower doses provide inotropy, while higher doses act as vasopressors. Phenylephrine, which can be used Phenylephrine, which can be mixed prior to use, can be diluted down such that you achieve approximately 100 micrograms per cc. When given as a bolus, phenylephrine is a pure alpha receptor agonist. The primary goal would be to increase systemic vascular resistance, but can potentially cause a reflex bradycardia in certain situations. Finally, vasopressin, which is used as a continuous infusion of either 0.04 units per minute or 2.4 units per hour. Its primary action is on vasopressin receptor and is meant to replace physiological vasopressin and potentially redirect splanchnic blood flow. A couple of inotropes that we oftentimes will see in the ICU. One will be dobutamine, which is the most common, which has primarily a beta effect, largely beta 1, much more than beta 2. The primary effect obviously will be to increase heart rate and also potentially lead to pulmonary vasodilation. Milrinone is an inotrope that acts primarily on cyclic GMP, and it works by increasing your contractility with a very slow effect and a long half-life. It also has the benefit of improving pulmonary vasodilation and allowing LV relaxation. Finally, isoproterenol is a primary beta 1 agonist with its goal primarily to increase contractility. What I would like to do now is talk about each of the vasopressors and inotropes in isolation. The first one we'll discuss is phenylephrine. Phenylephrine's primary action is a pure vasoconstricting agent. It's excellent to provide as an intermittent peripheral push to temporize your blood pressure in the setting of a decreased systemic vascular resistance. In general, we mix phenylephrine as 10 milligrams in a 100 cc mini bag, and then administer 1 to 2 cc's, which equates to 100 to 200 micrograms at a time. Because it's a potent vasoconstrictor, it may potentially reduce your stroke volume or your cardiac output. It is often not used as an infusion vasopressor of choice. You should only consider it when norepinephrine causes major arrhythmias, your cardiac output is known to be very high, or this is a salvage therapy. The primary workhorse in any critical care department now is norepinephrine. The primary mechanism is predominantly vasoconstriction, both arterial and venous, and some inotropic or chronotropic effect because of the beta 1 activity. It is a good drug for most shock states that have some amount of vasodilatory shock. The only exception would be anaphylaxis. It's really the first line now for septic shock management and a bridge vasopressor for other shock states. Epinephrine has both alpha and beta agonist effects. Its primary mechanism, when you look at it, in low doses is predominantly inotropy, and in higher doses predominantly vasoconstrictive. It is the first line vasopressor to be used during anaphylaxis, and second or third line for septic shock and mixed shock states, such as cardiogenic and vasodilatory shock. The primary side effect is obviously arrhythmia, as well as an elevated lactate. It is a potent splanchnic vasoconstrictor, and therefore has effects on metabolic stimulation. Dopamine. Dopamine has different effects depending on dose as well. At lower doses, it's predominantly an inotropic or chronotropic agent with some vasodilatory effects. At higher doses, it predominantly acts as a vasoconstrictor. When you use it, you should be using it in states where the blood pressure and heart rate are both low. Renal dosing to preserve kidney function does not work well with dopamine, and at present, it is considered a second or third line agent for septic shock. The primary side effect of dopamine is the high risk for arrhythmias, much more common and prominent than seen in norepinephrine. Vasopressin. Vasopressin is essentially used as an endogenously released peptide hormone, as an adjunct to catecholamines. It acts primarily on V1 smooth muscle receptors. It's best used during vasodilatory shock or as a second-line agent in refractory vasodilatory shock states like sepsis. It's given as a continuous infusion of 2.4 units per hour or less. The primary side effect is that at higher doses, you may start to see digital and splanchnic or cardiac ischemia. There is some theoretical benefit from a pulmonary vasodilatory effect, but again, this is just theoretical. Dobutamine is one of the most common inotropes that we use in the intensive care unit. Its primary mechanism is inotropy, chronotropy, as well as a vasodilatory effect. It's best used for cardiogenic shock states, as well as septic shock with cardiogenic or myocardial depression. Ideally, in this context, it should be used when patients are volume replete. The primary side effect of dobutamine really is arrhythmia, particularly when using doses of greater than 15 micrograms per kilo per minute. If a patient is under-resuscitated or volume deplete, vasodilation may unmask as a drop in blood pressure when initiating dobutamine. Milrinone is a very potent inotropic agent that we don't use as often in the ICU. Its primary mechanism of action is through phosphodiesterase inhibition by increasing intracellular calcium and increasing myocardial contractility. It's ideally used in patients with cardiogenic shock to improve cardiac relaxation and help with pulmonary arterial vasodilation. The major side effects are a longer duration of action and the tendency to potentially accumulate in our patients with renal failure. In summary, shock is a heterogeneous disease with multiple causes. The cause of shock is critical to determine the guide of ongoing management. This is one of the times where it's really important to both examine and take a history to provide important clues. When in doubt, always use norepinephrine as it's an ideal first-line vasopressor for most shock states.